Right, it's with a great pleasure that I introduce Dr. Adrian Wiestner. Dr. Wiestner is a tenured senior investigator and chief of lymphoid malignancy at the National Heart, Lung, and Blood Institute, National Institutes of Health, NIH. Dr. Wiestner scored multiple discoveries in CLL and mantle cell lymphoma that shaped and continue to reshape not only the way we treat CLL and these diseases, but also our deep understanding for this disease biology. So with Dr. Wiestner, you'll hear the truth, the full, unbiased truth, no matter what. So I would say, let your guards down and enjoy his story of targeted CLL therapy. Adrian, I look forward to learn not only from your slide, but also from your wisdom. Thank you very much for coming here. I keep forgetting doing this. Make sure that these are the right one here. That's it, right? Perfect, thank you.
Thank you for the kind introduction and invitation to be here with you today. It's a great pleasure and an honor to tell you about some of the studies we've done in CLL, and I try to weave that into the overall evidence that's emerging from different groups and trials. Here are my disclosures. So we have primarily industry support for ongoing clinical trials and some of the correlative analyses. I would, as a brief outline, I want to take you from the key pathogenic mechanisms to how we can target these to problems that arise with resistance to targeted therapy. Briefly touch on continuous single agent versus time-limited combinations. Give you some thoughts on special populations and outlook on goals for 2026 and beyond. So the key pathogenic pathways in CLL are now really well defined, and the first one has already been alluded to in the 1960s, is this resistance to apoptosis. The molecular basis is overexpression of BCL2 due to different genetic abnormalities, primarily the deletion 13q, the deletion of the long arm of 13, which deletes these MERS 15 and 16 that typically would downregulate BCL2 expression. So CLL cells have this high expression of BCL2, an anti-apoptotic phenotype. Oops, sorry. The other element is the driver of CLL. And I would really like to go as far and say the oncogenic driver of CLL is B-cell receptor signaling. Even so, we don't have the classic mutations that were described in diffuse large B-cell lymphoma, which are actually in the downstream signaling portion. In CLL, we have unique B-cell receptor structures that support the self-self association and a continuous B-cell receptor signal. And for one of these subtypes, it's actually really one specific mutation in the lambda light chain gene that leads to this self-self association. So there's a tumor mutation that is driving the tumor in this subtype of CLL, but it's a general theme. And so this then leads us to the two really most successful classes of drugs we have at this point to treat CLL. That's inhibition of B-cell receptor signaling with the most rewarding class of agents targeting Bruton's tyrosine kinase, and Venetoclax that targets this anti-apoptotic phenotype by inhibiting BCL2 function. So I'll spend some more time on the B-cell receptor signaling part. So again, it's the oncogenic driver. We have several targets within this pathway, and all of them have been tested clinically. So inhibition of Syk kinase inhibits B-cell receptor signaling, PI3K delta downstream, and then the BTK inhibitors, which have really proven to be the most effective, but also the best tolerated agents. With the first class of BTK inhibitors led by ibrutinib as first in class. We have a group of agents that covalently inhibit BTK. They do this, all three of them listed there, ibrutinib, acalabrutinib, zanubrutinib, do this through covalent binding, so an irreversible bond to a cysteine residue within the protein. So that protein is gone, is useless, but it can be resynthesized. That's the reversibility, right? When we stop a BTK inhibitor, after a few days, there is enough BTK being resynthesized by the cells, and that restores the signal. So in multiple trials, we've seen that the BTK inhibitors, as single agents or in combinations with an anti-CD20 antibody, beat all types of chemotherapy, FCR, BR, chlorambucil. In all these trials, shown here for FCR versus ibrutinib rituximab in the ECOG trial, you see the really tremendous benefit of chemotherapy-free treatment, first-line treatment of patients with dramatic differences in progression-free survival. And let me just point out that this is now also seen for the IHHV mutated subgroup, which initially was thought to not have a benefit from ibrutinib rituximab over FCR, but with longer-term analysis, also this group is better served by the BTK inhibitor than with chemotherapy. This is the ELEVATE-TN study that used acalabrutinib as single agent or in combination with obinutuzumab. The study is not powered and not designed to test whether the antibody adds to the single agent, but clearly you see that both acalabrutinib-based regimens beat, in this case, chlorambucil with obinutuzumab. And updated data, of course, supports this continued benefit that also starts approaching maybe a benefit in overall survival. So what's the role of these newer or kind of coming after the first-in-class? Acalabrutinib and zanubrutinib have been compared in randomized trials in relapse refractory CLL. In both of these trials, the shared observation is that we have less cardiac side effects with acalabrutinib and zanubrutinib than with ibrutinib. That's primarily atrial fibrillation, hypertension, and possibly also some sudden death on ibrutinib that seems to be somewhat less common with acalabrutinib or zanubrutinib, but that is never common enough to actually reach statistical significance. For the zanubrutinib versus ibrutinib trial, there was also a suggestion that there is a better progression-free survival with zanubrutinib, at least in that study it was. It was not for acalabrutinib versus ibrutinib. They had virtually the identical progression-free survival. So whether really one of these is more effective than the other, I think can still be debated, is being debated. But they have advantages from a tolerability profile. So when we started with ibrutinib in 2012 at a clinical trial at the NIH, and I think virtually everybody I talked to in the lymphoma field said, well, with single agent, you won't get very far. You will have resistance, that you have to immediately go to combinations. Well, we stuck with single agent, and yes, we do see resistance. Our longest patient has had his 14th year on ibrutinib this January, and he had about 6 prior regimens, so definitely it can work long-term. But the resistance we see is either early, and that is typically unrelated lymphomas, so another B-cell malignancy, or it is transformation of the CLL into aggressive lymphomas, or Richter transformation. These types of resistance typically happen early. The patients typically respond from their CLL component, but the Richter's is either less sensitive or not sensitive at all, and that's what emerges within the first 6 to 12 months. At later times, we see typical progression. We see a progression that's typical CLL type. And this CLL now carries mutations in BTK or PLC gamma 2. And it's immediately clear why these mutations confer resistance. The mutation in BTK is typically affecting that cysteine residue, so the covalent inhibitor cannot attach anymore. These drugs have a short half-life, so the effect is cleared rapidly, and you get either no inhibition or just a poor inhibition of BTK function. Or we have mutations immediately downstream of PLC gamma 2. This is from multiple studies. We find these mutations in up to 85% of patients. So this is the dominant genetic event in resistance to ibrutinib. Okay, so the prediction in some ways is correct. Yes, with single agent you may see resistance. But this resistance is not something else. It brings back BTK function, right? These mutations, what they do is allow BTK to be functional again. So it actually validates this target. It tells us that BTK really matters so much to the cells that the resistance focuses on bringing that signal back. So we spend an inordinate amount of time in trying to really understand everything about these resistance mutations, and that's now going soon into its 10th year or so. But let me show you some highlights from that. First, one comment often is that, well, the mutations are only affecting 10% of the cells in circulation. So how does that cause resistance if only a small part of the tumor actually carries the mutation? Well, yes, that can be true, but what I'm showing you here is the analysis of a patient that we studied by single-cell mutation sequencing. So we know for sure that all that I'm showing you here is happening in separate cells. So this clonal population we talk about is not an identical copy of each other, right? So in a first branch, this patient or this CLL evolved with having two different SF3B1 mutations. So we have two distinct populations. Within those populations, one set develops a PLC gamma mutation at the bottom of those lines, whereas in the other subpopulation, we see emergence of, 5 different BTK mutations. And because we did single-cell sequencing, we know every mutation is in a separate cell, in a separate subgroup of the tumor. So we deal with the complexity, right? The Greek mythology would be Medusa's head with all the snakes. So because we now know that this is in different subpopulations, we add up the total mutations. And when you then look at it, is many of these resistant patients have virtually all their cells carry a mutation, either in BTK or in PLC gamma or a combination of it. But yes, there are some patients where the explanation doesn't quite hold. At the bottom of this panel, we actually have 2 patients. Despite looking at everything, sequencing back and forth, we don't find BTK and PLC gamma mutations. So in a rare subset, yes, there may be other genetic mechanisms. But another explanation for relatively low tumor mutations in the circulating population is that the cells are not the same in all compartments. This patient, PD15 there, with a relatively low 5% frequency of the C481S mutation in the blood, 75% of his cells in the lymph node carry the mutation, and over 50% in the bone marrow. So yes, we're used to studying the blood in leukemia, but we have to keep in mind that it's really in the lymph node that things happen. That's where the cells proliferate. That's where mutations occur. So these clones don't necessarily equilibrate, and the blood may not give us the complete answer. So again, we're at the same point that we have these BTK mutations. They tell us that the cells really need BTK signaling so we can retarget BTK. And this is very nicely proven here with pirtobrutinib as a non-covalent inhibitor. So that drug does not care about the cysteine. It can be there as cysteine, it can be mutated, it doesn't matter. And you see this really impressive waterfall plot that pirtobrutinib in this setting is working in patients who discontinue the BTK inhibitor for toxicity, but it also works for patients who progressed on the BTK inhibitor. That's the darker green bars. It works for patients who had previously also received Venetoclax. That's the red stars. And it also works in patients who have or don't have the cysteine mutation. So even if a patient doesn't have that cysteine mutation, retargeting BTK brings a response. I think that again validates how valuable this signal is to the cells. Okay, but we know that tumors evolve, so the evolution continues. And this is an example of a patient who had a C481S mutation, started pirtobrutinib, had a wonderful response, and then relapsed around a year, and the C481S mutation is gone. But now there is a new BTK mutation in 528W. And this work from the Memorial Sloan Kettering group nicely summarizes here from an early study the type of mutations they saw in patients progressing on pirtobrutinib. No C481S, as expected, but several other mutations can now confer resistance to pirtobrutinib. And this brings out an interesting point. With different types of inhibitors, we actually see different types of mutations. In this graph, you see the clinically documented BTK mutations by type of BTK inhibitor used. So ibrutinib has the most mutations because it's the longest studied. Okay? But when you look at it, it's mostly centered around the cysteine mutation. Acalabrutinib and zanubrutinib also have these cysteine mutations. So switching from ibrutinib to acalabrutinib or zanubrutinib will not work. This shared mutation is conferring resistance to all of them. Interestingly, we see some mutations, acalabrutinib, this T474I, that's uncommon with ibrutinib, not reported on zanubrutinib. On the other hand, we have the L528W mutation towards the bottom that is more common in zanubrutinib than we see in the other BTK inhibitors, the covalent BTK inhibitors. And then in red, you see the non-covalent pirtobrutinib. No mutations in the cysteine, as expected and understandable from mechanism of action. But we see other mutations. Some of them overlap, some of them don't, with the covalent BTK inhibitors. So this certainly, the tumor continues to evolve, but it again tells us it really cares about BTK. So what's the next strategy to go against BTK to overcome this? So we're changing the paradigm now. We're going from inhibitors to molecules that can completely degrade BTK. They do this by a hook which binds BTK, a linker, and then a harness that brings in cereblon, which has the activity of ubiquitinating BTK, targeting it for proteasomal degradation. So we're basically sending BTK through the internal waste disposal system, get it completely degraded. The Western blot below that shows you that what we did in the lab to show at even very low concentrations, we can get completely rid of BTK, and that's true for both wild type and C481 mutant. So this strategy is not impacted by mutations. So this is still in early phase trials. This is work we did together with NeauxCancer. They have two molecules in clinical trials. Show you one example, one patient vignette from my clinic. Patient with Waldenstrom's, macroglobulinemia, lifetime over 10 regimens, but the last 4 were for transformed lymphoma. And so she came back after her last treatment, again with this PET-avid long lesion there in the left thigh, with 2 cycles, 2 months of treatment, oral therapy. She's in complete metabolic response and has maintained this for over 2 years. So single agent BTK targeting restores the response here. So the other molecule from NeauxCancer has recently received a name, bexobrutideg. This is data presented at ASH last year, and you see here an impressive waterfall plot to point out the stars are CNS involvement in CLL. These patients also responded. And below the waterfall plot, you see actually the mutational profile that is complex, contains multiple types of BTK mutations, and this degradation still works. One advantage is this is an enzymatic reaction. You don't have to have a long on-target residence. If the molecules bump into each other, ubiquitin can be deposited. That's covalent attached, that stays attached. The drug can fall off, the ubiquitin stays. The protein is targeted for destruction. So this is a very different paradigm than what we have with inhibitors. Okay, for balance, let me get also to Venetoclax. So studied initially as single agent. With single agent, one saw mutations. Again, immediately understandable why these mutations happen. They abolished the binding of the Venetoclax to BCL2. But that's not how we use Venetoclax now. Venetoclax was quickly taken into combination regimens that are time limited. Here showing one of the first trials comparing Venetoclax to Venetoclax obinutuzumab. And this is the outcome. Of course, it was much better than chlorambucil. With Venetoclax, we have another element that comes into play, and that's assessing minimal residual disease. So basically, what this nicely illustrates here, I think, is when we talk about complete remissions in CLL, it just means we don't see it with relatively superficial ways, right? Exam, a blood count, a normal ALC. But when you go with flow cytometry, in many of these patients, you will find disease. And so here we're just pushing the envelope to see how much CLL is actually left. And I think it gives us good information about types of treatment. It may not be something, personal opinion, that we really need to integrate into everyday practice, but it's an interesting readout of what a drug does. So here with Venetoclax obinutuzumab, a high rate of such undetectable disease, so beyond clinical staging. In green, you see these undetectable for MRD, but you also see that after a peak at the end of therapy, now during just observation, therapy-free, the rate of undetectable disease declines. We start detecting low levels and higher levels. So I think what this can tell us is, yeah, fantastic, we get deep responses, but they are not equal to cure. It looks like these responses have a shelf life and eventually CLL comes back. What's clear is not getting to at least the level below 1 in 10,000, that's the easy, by flow cytometry, easy to assess level of undetectable MRD, that's bad news for progression-free time. But after that, it almost doesn't matter too much. Is it 1 in a million? Is it 1 in 100,000? Those curves are overlapping. But it's not good news if you don't get to below 1 in 10,000 with this approach. What about more intense or other comparisons? So this is the German CLL study group, FCR versus rituximab venetoclax, obinutuzumab venetoclax. Here they call this GV, it's VO, because it's Gazyva or obinutuzumab, whatever you use, right? G and O in this are interchangeable. And then the triple combination adding ibrutinib. This is the PFS data published initially in New England Journal, updated in 25. So if you look just at the 4-year PFS, obinutuzumab venetoclax gives you a 4-year PFS of 82%. Keep in mind that's 3 years of that is without any treatment, right? So it was a 1-year treatment and you're off treatment, and at the end of 4 years, you still have 82% of patients have not progressed. There is a high rate of undetectable MRD, both for obinutuzumab venetoclax, so the GV regimen here. Slightly more undetectable MRD when you do a triple combination, but you pay a price for it. More neutropenia, more infections, and you get the toxicity of the BTK inhibitor, hypertension, atrial fibrillation. So absolutely not clear whether it's worth the squeeze to make it a triple combination. The other approach to combination was to define acalabrutinib as the backbone, and this is the amplified trial, chemoimmunotherapy versus acalabrutinib venetoclax versus triple combination with the addition of obinutuzumab. The trial was designed to test whether acalabrutinib venetoclax beats chemotherapy. Yes, it did, and it got FDA approval for that. So this is an approved frontline regimen now that has been better than chemotherapy. Whether you need the triple combination is at times debated. Again, you definitely pay a price, more neutropenia, more infections. So with undetectable MRD, people have started to think about very sophisticated concepts of using undetectable MRD as how long you treat, how intense you treat. This is one of the trials that has done this in the most consequential way. They give ibrutinib venetoclax. They measure undetectable MRD, or actually the rate of decline in measurable disease. The faster you clear, the less your total treatment duration. If you take long to clear, your time on drug gets doubled up, and you may actually be treated for a long time. What that resulted in is that IHHV unmutated CLL patients had a median of 24 months on treatment, whereas IHHV mutated patients had 44 months. So I have to show you the progression-free survival that shows that this is super approach compared to FCR if you look at this progression-free survival curve. The downside, I would argue, is that you totally overtreat the patient population that does well in general. And that's the IHHV mutated CLL patients that are just almost 2 years longer on combination therapy that causes neutropenia, maybe diarrhea, maybe AFib, maybe hypertension. So I think this was a very interesting academic exercise. I don't think that's ready to be implemented in practice. Let me quickly show you, people say with single agent BTK inhibitors, you do not get undetectable MRD. That's not true, you just have to be patient. This is our data now, continuous ibrutinib from 2012 through however long patients stay on it. This is the measurement of UMRD in these patients. It takes a median of 5 years to get below 1 in 10,000 CLL cells in the blood. But except for 1 out of these 13 patients, everybody has maintained their undetectable MRD. Okay, on continuous therapy, but nobody on continuous therapy, except 1 patient, has relapsed. So, promised you to quickly go over special populations, and I'll speed up a little. So, is it time, with all these effective treatments, is it time to just ditch, watch and wait? Nobody likes the term anyways, and just treat upfront for diagnosis. And this was again and again and again studied, and this time here with ibrutinib. Of course, the event-free survival, if you count an event as needing treatment or progressing, for patients who are not on treatment, obviously they will have such events. So this curve will always look good, but the resounding answer here again was no, don't do this. Yes, ibrutinib is effective. It is a treatment. The untreated patients will have progression and may need treatment when they need it. But everybody who is on treatment has the risk of side effects. So they had AFib in almost 6% versus less than 1% for placebo. They had hypertension at least twice as much. They had bleeding 2 to 3 times as much. So really, is that worth it? We should reserve treatment for when patients need it. What about the TP53 mutant patients, TP53 alterations, either deletion 17p, TP53 mutation? Ibrutinib works as single agent for actually a surprisingly long time, 4-year PFS, 80%, 79%. You can give Venetoclax obinutuzumab, it works, but the progression-free time for patients with deletion 17p will be short. These patients will relapse earlier. So their median PFS was actually 49 months. So many of us would argue it's better to be on continuous therapy if you have deletion 17p, TP53 mutations. What about Richter transformation? So this is a quintessential picture of Richter transformation. With R-CHOP, I'm not showing you this, virtually everybody has relapsed by the end of the first year, and virtually everybody is dead by the end of the second year. So R-CHOP is not really the way to go. What people have tried here, the Dana-Farber group, Venetoclax plus more intense anthracycline-based chemotherapy, high overall response rate, but the median PFS is still only 10 months. And it's a hard regimen to give. So there are many other attempts to do this. One of the almost most controversial, promising ones is this combination of an anti-PD-1 plus zanubrutinib with a median progression-free survival of 10 months. We have data for CD19 CAR T cells, we have data for bispecific antibodies that were discussed. The median PFS is typically short, at best by about 6 months. So these patients should just go into clinical trial. There is really a need to figure out what needs to be done. But there's a big caveat with interpreting these studies. And that is, what is actually a Richter, right? Yeah, it's transformed CLL. But how do you really know it's transformed? Who tells us it's transformed? Well, this is a paper from expert pathologists. They tell us the upper panel is CLL, the lower is DLBCL. If you just glance at it briefly, it's actually hard to see the difference. In the DLBCL, the cells are larger, they're more densely packed, and you get this starry sky appearance of holes in between the blue. You don't see that in CLL. They're a little more dispersed, they're smaller. Okay, what about this one here, right? So this is a CLL biopsy, shows a proliferation center. Now let's look in this proliferation center. And these cells have nucleoli. They are a little larger. Is that Richter's? This paper, expert pathologists have coined the term accelerated CLL. And in contrast to Richter's, this is typically responsive and can be maintained for years on a BTK inhibitor. And then we get to pseudo-Richters. Now look at the top. The top is what was called Richter's initially. But when you delve into the clinical context, the patient stopped the BTK inhibitor to undergo surgery. The lymph node biopsy taken during surgery is what we see in the top panel. Yes, there are mitosis, the cells are pretty large, but they're by far not as densely packed as what you typically see in DLBCL. Restarted BTK, and the next biopsy on BTK shows you a typical CLL panel. So what is the short message of a long presentation? Always question the diagnosis, always. And if Richter's is just read in one pathology suite, it needs to go to another pathology suite to actually know what we're dealing with. And it's probably never wrong to just go back on the BTK inhibitor. If it works, it probably wasn't Richter's. Okay. Do I have 2 more minutes? Okay, quickly, I won't go into every of these goals, but let me also give you just 3 highlights here about private thoughts. I talked about MRD. It's a tool, it's interesting, it's academic, but this is our long-term data with the ibrutinib trial. Patients who we looked at 3 years, are you in undetectable MRD or not? And most of the patients were not. Most of the patients were either high MRD, so more than 1% of the circulating cells are still CLL cells, or low MRD, somewhere in 1 in 1,000 white cells is still a CLL. On continued therapy, these patients do perfectly well. Tells us there is no reason to call them treatment failures. As long as they are side effect free and happy with their treatment, that's fine. They don't need any heroic interventions or intensification of treatment. Affordability. Ibrutinib could soon be a off-patent, affordable drug. It may not happen immediately. That AbbVie disclosed the patent is to expire in 2027. No generic is in the pipeline, but the patent is about to expire. And I would argue ibrutinib is a fantastically good drug. The only problem is that we have acalabrutinib and zanubrutinib that is slightly better tolerated. So I really take the stand that ibrutinib is a fantastically good drug. If it's affordable, off-patent, it's a very good option for many people. What about immune function? As we know, infections remain one of the caveats, and so studying different treatments for how well they preserve immune function or strategies to restore, I think will actually take center stage over the next years. What we did here was a vaccination trial with hepatitis B and Shingrix vaccines, herpes zoster vaccines. So with hepatitis B, where we tested de novo immune response, we see very low responses in CLL patients. And BTK inhibitors virtually prevent the response. With the Shingrix vaccine, on ongoing BTK inhibitor therapy, we do get some vaccination response. That's the green. In blue is treatment-naive CLL patients. But it's both the antibody and the cellular response are impacted by being on the BTK inhibitor. So I think it just primarily reinforces the earlier we can vaccinate patients, we should do it. right? So basically at the time of diagnosis, probably going over all the vaccines would be a good idea. Okay, so with that, I would really like to thank for especially our patients. They undergo a lot more biopsies, blood draws, and procedures than they would in standard care. That's possible, and thanks to this unique hospital system in Bethesda. So we see all patients on clinical trials, all care is free. I mean, they have to make it to NIH at one point, but then from there on is also travel assistance. And we see a lot of patients who also really come because they want to participate in research, fighting back this very American approach. I'm European by descent. So this very American, let's fight back, right? I have a disease, I want to fight it by giving to research. That's what many of the patients motivate to come. And then I have really a fantastic team with NeauxCancer, having been for more than 2 years a very valuable component of that team. And so thank you all for your attention.
All right, we still have about 15 minutes for questions. I'd like to invite the panel to come back to the podium to take questions from the audience. So the panel is ready for your questions, guys. I can get started with you, Adrian, while everybody's ramping up. Those who had progression on covalent, on ibrutinib in your study, and did not have any detected resistant mutation in the blood, those the last 2 or 3 patients in the bottom, did you find anything in the lymph node for those particular patients or not? Like, did you have somebody or patients without any detected mutation, any compartment?
So they did not have mutations.
There you go.
Does it work now? Yes, okay. So they did not have mutations by exome sequencing, by candidate sequencing, but I don't know if we had a lymph node in all of those 3 at the bottom that didn't have it in the blood. I would have to go back, Steve.
Yeah, but it's interesting that the compartment matters in those cells, and that definitely, for me, it explains how a low VAF might be associated with progression on those BTKIs. Yeah. Okay. Other questions? I have a few questions actually for the rest. Dr. Davis, with the polar chip rising after, I don't know, almost 3 decades of failure against R-CHOP, do you foresee this lasting for a long time? I mean, you showed us the bispecifics in the second line. Also, we're aware of some data in the front line, early data. Do you think that will change soon, so we don't have to argue whether we should do polar chip in the front line? Is it going to survive for a long time like R-CHOP did? I know you don't have the crystal ball, but what's your take on that?
That's a great question. I think it'll be interesting because there are studies that are comparing novel combinations with R-CHOP and novel combinations with polar CHP. So I think there will probably be some regimens that show superiority in things like PFS. I personally believe that overall survival benefit is still the gold standard, and we need to see a novel therapy that improves not just PFS but OS in order to really replace R-CHOP definitively. So I think actually in the foreseeable future we'll still see a lot of R-CHOP type chemotherapy because it's very feasible to administer.
Yeah, I can't agree more with you. We need OS in DLBCL. There was an old study of R-CHOP with maintenance LEN. That one had PFS benefit, and yet no one used it, arguably because it has more toxicity. In AML, Dr. Cicada, we have you showed us the Ven-Aza data. Obviously, it's not a home run, especially in the older population. I see you use more triplets and quadruplets in there. Any quick comment on how do you choose between these regimens and
Yes.
and why?
Thank you for the question. So I think the data from ASH 2025 was just kind of a proof that ASA-Ven is a good backbone, but I think we can still do better. So the problem with ASA and Ven is that it gave the ability to us to kind of open and close the faucet. So patients that were having a lot of complications, we could manage the complications for those patients, and they had a better overall survival. And now that we can manage, the days of venetoclax on real time, now the question is, how can we less myelosuppressive but still kill more AML blasts? So now I think, and that's why I'm moving more towards the clinical trials of triplets, because I think we have to just learn how to do with the myelosuppression, and that takes a lot of experience, and that takes a lot of regimens and back and forward. There's some very interesting data with cladribine, low-dose RSV, venetoclax for patients that, especially older than 60 years of age, and that also challenges, and that comes with interchangeably ACE and VEN and this, and the results are impressive. So, of course, we need randomized clinical data to decide which one's better, but for now, we're just, in clinical trials trying most of these combinations.
Okay. All right, if no further question, that concludes the talk this morning. Thank you very much for attending.